Thank you for the introduction, and thank you the Vietnam Society of Radiology and Nuclear Medicine for the invitation. So I would start my talk. I changed the title a little bit to make it more interesting. It's about the molecular imaging in Alzheimer's disease, especially in the era of the blood biomarker. And this is the overview of my slide. I will describe about the molecular imaging technique, CSF and blood biomarker, and compare their diagnostic performance, as well as the potential clinical application and the future. And just to review to you about the ATN criteria that has been proposed since 2018. The A is the one that we believe that it causes proteinopathy of amyloid and cause the toxic to the brain and cause the damaging of the neuron. And the leakage of neurofibrillary tangle can be detected and described as tau pathology. And then it will cause the neurodegeneration as the later process. And all this process can be detected by the biomarker, other imaging, or the fluid biomarker, including CSF or blood biomarker. And then the clinical symptom can be proceed later, maybe 10 or 20 years after the detection of this biomarker. And on the right side is the how we can detect by amyloid PET, which directly evaluate the change in the brain, or indirectly by measure the level of change of CSF or blood regarding this amyloid or tau pathology. And at the lower step is the end pathology that we can detect by the change of metabolism in the brain or the volume change in MRI. And these are the milestones of the biomarker of Alzheimer's disease. Actually, the first biomarker were CSF of amyloid and tau, which detect before 2000. And then for the first PET, amyloid PET was developed in 2004. And along the way, between that time, the fluorine level PET tracer, which has been FDA approved, was developed during 2010 to 2012. And then the first tau PET was developed in 2013, and plasma become more available recently, starting from plasma amyloid beta in 2018, and then plasma tau in 2020. And during that time, the clinical trial also started, and some of them also use this biomarker to select the candidate for the treatment. And since 2018, that the first ATN criteria was announced, and some debates are proposed because there are somehow different to select the patient, and sometimes there are controversy about what about the amyloid negative but tau positive, or A and T negative and N positive. And then the same group, they revised the criteria and changed the ATN from A and T and N, but put it as the core biomarker called core number 1 and core number 2, which core number 1 include A, and they separate T into T1 and T2. And as you can see that in the core number 1, the main players still amyloid PET, which they believe that it is the primary pathology that caused the disease progress to be Alzheimer. This one for PET, still amyloid PET, but for CSF and plasma biomarker, they use AB42 and also T1, which are phosphorylated tau. There are different number of these biomarkers, but this one are the core one, which is need for the diagnosis. And another core is core number 2, which is tau. For the PET, they still use tau PET, but for plasma, the tau in this category does not include the phosphorylated tau, but more specific to tau pathology. The reason behind this because the p-tau with the correlation study, it has more correlation with the amyloid pathology in the early stage. And then in the later stage, when patient has a more symptom or more change in other imaging, this T will also have a correlation. And then for the N criteria, the FDG and anatomical MRI is still the imaging of choice for detected the pathophysiology also from AD or other disease, because neurodegeneration is not only specific for Alzheimer, but also other disease that can cause dementia. And in this criteria, they also suggest how to use the biomarker for diagnosis. We can use to detect A or T1 pathology using amyloid PET or CSF or plasma with different aim for diagnosis. But for staging, we should include amyloid and tau and sometimes FDG to see how much severity of the disease. The more pathology we can detect that become positive in the brain, that means the patient has more developed symptoms that can then convert it to have dementia later. So the biomarker for approach Alzheimer's disease has changed from the clinical diagnosis and imaging or other biomarker just for the supportive. Now the biomarker has become very crucial to help the diagnosis and also guide the treatment. And this is just to show that for PET imaging, we can see the change in the brain directly and has proof evidence to correlate with the brain autopsy. But for CSF and plasma biomarker, it is indirectly detect if the amyloid in the plasma or CSF reduce, that means it may aggregate in the brain. And if we detect the tau in plasma, CSF, or blood, it means that the neurodegeneration or the neuron degrade and leak it into the plasma or CSF. So for amyloid tracer and application, we have carbon-11 PIP and then fluorine 18 label tracer. And the diagnostic performance is very high because we have to validate with the brain autopsy. So it can enable early diagnosis to see the accumulation of this pathology in the brain and also detect it way more earlier than the clinical symptom develop. And these are the amyloid PET and tau PET imaging that we can see how much accumulation of amyloid and tau in the brain. And recently, we also use quantitative number called centiloid to make it universal for any amyloid PET to compare. And we also use this number to grade it as negative, like less than 20, or in some paper, they use less than 11 or 10. And 50 is the number that show that we have a lot of amyloid in the brain. And for selecting the patient into the clinical trial, most of the study use more than 24 or more than 30, but before they use 40 in some trial. So in some trial, they also use this kind of number to compare the dose and the type of the drug that can lower how many centiloid. The more they can lower the number, that means the drug is more effective. And now we also use this number that if the centiloid number reduced to the amount of negative amyloid PET, let's say 11 or 24, we can stop the drug to prevent the side effect. And for tau PET imaging, we can use it to evaluate the advance of the brain pathology by the accumulation of the neurofibrillary tangle deposition. And these are the updated appropriate use criteria for both amyloid and tau PET imaging from Alzheimer Association and SNMMI. These are the strong evidence that they suggest to use amyloid PET and tau PET. To simplify it, we will use it in the case of uncertain diagnosis, like the patient has dementia with maybe Alzheimer's disease, but happen in the atypical age or with atypical presentation, or we want to select them into the clinical trial for the specific target treatment. The similar application apply to tau PET imaging at the moment to support the diagnosis. And these are compared between the trial of Trailblazer and appropriate use recommendation. So they use positive amyloid PET for selecting patient, and some, like Trailblazer study, also use tau PET to evaluate the pathology, because if you have only amyloid, it may not Alzheimer, because there are other diseases such like dementia with Lewy body or very old age that can have amyloid in the brain. So they use tau to evaluate if this is Alzheimer, or if the patient have too much tau in the brain, that may mean that the brain is too severe to help. So they will exclude that kind of patient. But for the appropriate use recommendation in general, tau PET is still optional. But for it, I want to highlight the table in the red color, because the exclusion criteria is also the proven pathology of the brain except Alzheimer's disease, because the patient may not be suitable for the treatment. And this kind of diagnosis may be not detected by amyloid or tau only. So we may use other imaging techniques such as FDG, because FDG not only to show the pattern of Alzheimer's disease and the severity of the disease, but it also shows the co-pathology, which means if the patient have Alzheimer's disease and other disease together, you only treat Alzheimer, but those pathology cannot be treated. So the patient may not respond to the treatment. So this is something that we are discussing more and more recently. And for CSF biomarker, the AB42 level will decrease if they accumulate in the brain, and tau protein will increase. And more recently, they use the combination of amyloid beta and tau together to enhance the diagnostic performance. And for blood biomarker, which is just approved in 2024 by FDA. So now in 2024, they have the recommendation of using blood biomarker, and FDA just approved it in this year, May. So it will become more accessible and also be a player in help selecting the patient. And these are the timeline of detection of pathology. It starts with the blood and CSF, and then they have some window period to accumulate in the brain. So we can see the change in the blood or CSF earlier than we can see the change of this biomarker in the brain. And these are the diagnostic performance of biomarker by PET. To simplify it, is more than 90 sensitivity. And these are for the CSF, and these are for the plasma biomarker. There are some gray zone of different plasma biomarker. But the plasma biomarker can be affected by some pathology, like the patient takes some supplement or have chronic kidney disease or other genetic disorder or some disease that can affect and cause abnormal plasma protein. So to compare it, we see that the PET amyloid is about 94% here. And for CSF, if we use just only CSF, single biomarker is a little bit low, but if we can combine it, it can increase almost slightly amyloid. And plasma biomarker is because there are still lack of evidence, so now it may be lower sensitive compared to amyloid or CSF. And these are the results from our center. Using amyloid PET compared to plasma biomarker with the clinical diagnosis, we still see that amyloid PET has a more AUC or area under the curve compared to plasma. And for the challenge and limitation, still have, we need the technical standardization among these biomarkers and also the economic accessibility. In terms of that, plasma may be more available and PET is more cost compared to plasma and CSF. But for clinical implementation, somehow plasma or CSF cannot answer all the question, so we need to combine it. And there are discordance between biomarkers. There are some paper that amyloid PET and CSF can be have the different result up to 20%. And there are head-to-head study that in that discordance, PET is the one that is correct compared to the brain autopsy. And the same thing happened with tau PET and CSF p-tau as well, that the concordance may be from 70 to 90%, depend on the clinical trial or how you select the patient. And there are some window gap that you need some time for the change in CSF to accumulate and change enough, and then the lower the CSF amyloid beta up to certain limit, and then you can see the change in the brain PET. So how to interpret this discordance is still challenging, because there are some trials that if you see the red and the blue color, there are concordant between CSF and MRI. And if we compare the change, how many patients that change into dementia later, MRI predict that converter better than the plasma profile. And for CSF and PET, if we see discordant, the PET change can predict the converter more than MRI. And also the ATN classification, I don't have time to go through this. And also challenge in atypical Alzheimer disease that plasma or CSF cannot differentiate type of Alzheimer, but other imaging such as FDG, they give the different patterns, so we can have a more sophisticated diagnosis for this patient. And these are the comparison. You can go through this paper from JNM. They show that for CSF or plasma, the cost is their advantage. But for PET, it has more specificity and more patternization, so you can give more accurate diagnosis and specific disease diagnosis. For the future direction, most of the guidelines suggest the combination of biomarker using the multimodal integration, and some suggest that AI can help combine these results and help us to give the correct diagnosis, and maybe the next generation biomarker that can have more specificity and specificity. And these are the change from the guideline in 2023 that use only FDG PET, tau PET, or MRI to select the patient for treatment and diagnosis. But in 2025, we suggest that if you have clinical suspect of a patient with Alzheimer's disease, You can use clinical and MRI based to select if the patient fulfill criteria of that. You can use CSF or amyloid PET to help selecting the patient. So these are the same guidelines suggested by Alzheimer Association that we use plasma biomarker as the triage. If the patient have the positive level by blood, then we should continue to prove that it is the real pathology for Alzheimer by PET or CSF, and then select the patient and use imaging to follow up the patient to see the change after the treatment. And this is the last one that suggests how to use plasma biomarker to evaluate, and also PET imaging to see the change in the brain, maybe by centiloid change. So this is the key takeaway for you, that the biomarker keep reward and we need to follow if we are in the field of dementia, and PET imaging has the advantage to direct visualize the change by amyloid and tau, and also the neurodegeneration by FDG PET, and it is essential for treatment eligibility and monitor. For blood biomarker, it is usable for screening in primary care setting, and the cost effectiveness should be evaluated. For the clinical impact, we use this biomarker based in early detection and also help to treat the patient at the right time, and we should integrate this biomarker to the best of their complementary benefit, and this can lead to precision medicine. And thank you very much.